Dr. Little. He was appointed a clinical professor within the department, Alex. He's a well-known thoracic surgeon. He has been chair at 2 institutions, one at the University of Nevada, and I'm happy that he is joining the ranks. As many before him, Al Cohen and Robert Zollinger, we do have notable names amongst our faculty, and I hope that Dr. Little will play a major role within the division of cardiothoracic surgery. Dr. Poston, who joined us about 2 months ago, is going to speak to us today. I also would like to take the opportunity to thank one individual in particular, Mike Moulton, for making the transition after Dr. Copeland's departure a much easier one than it could have been. He kept the boat afloat, and I'm very grateful to him in that regard. With Dr. Poston's appointment as the new chief, the college, the hospital, has made a number of recruits possible. We have recruited already and signed and received 2 signed contracts. There are another 3 individuals that we are in negotiations with, and we expect those contracts to be signed within the next few weeks, so that by the end of the year, the division of cardiothoracic will be enlarged by a total of 5 more faculty members, so that the CT division is going to be what it used to be in the 1980s and 1990s, one of the leading programs in the country. Dr. Poston, I have introduced him before, is going to talk to us today about an update on robotic heart surgery at UMC. And again, this is part of a bigger program in CT for CABGs, eventually for mitral valves, but also within the department. As many of you know, NOTES is going to be one of the cornerstones in general surgery in the future. And this is just part of the general direction going into the more minimal invasive procedures. Robert, welcome.
So I've been here 100 days, so this is kind of a 100-day report like the president might provide as to what's been going on in cardiothoracic surgery. And I also hope to provide some comments that would be helpful for surgical innovation in general, so the people that here that aren't specifically focused on cardiothoracic might get some interest from that aspect. The overview of the talk, I'd like to really remind you what I'm talking about specifically regarding robotic CABG, coronary artery bypass grafting, and then emphasize that it's a good technique, but it is always associated with controversy for a variety of reasons. You know, coronary bypass has been the sacred cow of cardiac surgery, and trying to change it is tough. It already gets excellent results, and so now we're asking to change it, and that can bring controversy. There are factors that will help. Change management principles. This is right out of business school, probably your first week of business school. They'll start talking about change management principles that they understand quite well in business, but in medicine we oftentimes stumble upon these rules. I think having a business plan is important because this affects finances, to be asking for expensive toys and be spending longer time in the OR trying to do innovative things. And so you have to have a vision, a business plan and a vision. And the vision is that patients prefer less invasive. We've seen this in every surgical discipline, and it's true in heart surgery. So what I'm talking about with robotic surgery is taking down bilateral mammaries. And that's, if you need one graft, then it's just a single mammary. But the advantage of bilateral mammary harvest, you can do it from unilateral ports on the left side, cross the chest, get over to the right mammary, take down the left mammary. Without a sternotomy, I get the benefits of these 2 excellent conduits, which have been known to last longer than saphenous vein grafts or any other conduit, even an arterial or radial artery. Then I do the distals through a thoracotomy. There are those that do the distals with the robot. The robot has enough precision to do that, but in my experience, having done a few, I've found that it increases the OR time and doesn't necessarily provide any different clinical outcome. So I've stuck with the hand-sewn technique using the same needle driver, the same Prolene suture that I would use if I did it open. One way to expand the number of candidates for the surgery is by doing a collaboration with cardiologists in a procedure called the hybrid approach. And that can be with PCI first. If a patient had a culprit lesion that was in the circumflex or some area that wasn't easily graftable, we would do that lesion first and then come to the OR on Plavix. In general, that's fine. Doesn't seem to increase the amount of bleeding. We certainly have outliers on occasion, but in general, they do good with a minimally invasive approach, different with an open approach. The second way would be surgery first and then followed by PCI. Then you don't have to be in the OR on Plavix. We are developing a hybrid OR here at this facility, which would get rid of some of those logistical issues. But the key is to have that collaboration with the cardiologists, people that buy into this. You know, not every cardiologist does. They're very attracted to the conventional approach of surgery. They know the results they're going to get. They want to have the framework in their mind of either stenting or surgery. You know, once I'm done stenting, then I want you to do the most definitive surgical operation possible. The real question, the way to answer that debate is, what's the value of doing this procedure? Or any innovation, that topic comes up. What's the value of spending longer times with a learning curve and using expensive technologies? In the hospital, value is oftentimes code for cost. Now, we've got to expand beyond that, because if you do, surgical innovations won't get past first base. They're always going to be more expensive. Well, I guess I wouldn't say always, but in general, going to be more expensive than the conventional approach. Occasionally, there's an innovation that actually reduces costs, but in general, they increase costs, but they increase revenue. If you're going to do things less invasive and bring patients into the hospital that otherwise wouldn't come, then you're going to increase revenue. And there's a variety of other benefits that I'd like to expand upon on this talk about the revenue-generating benefits of innovation that don't necessarily end up on the standard profit and loss sheet of the hospital. And so you have to work with them to measure these things and get credit for those things in order to have that reinvested in your program. From a patient, the term value doesn't involve costs at all. Remember, they have insurance. They don't pay anything. What they care about is, what are the clinical advantages? What's the advantages from their perspective? And for minimally invasive heart surgery, it's avoiding the sternotomy. Cosmetic advantage for an incision like this compared to sternotomy, but more importantly is the quicker recovery. That's the thing that I usually try to emphasize to patients, that if that's a key value for you, then this is a good procedure. I don't want to get unrealistic expectations, but I have seen that to be a consistent benefit. The pain resolves quicker. It's not necessarily less painful. In fact, some patients it's more painful because the ribs have more nerves than the sternum, but it does resolve quicker. Most of my patients after they're discharged are not on pain medications. And then we can obviously avoid sternal infection if we're not cutting the sternum. That's the most important reason why we can harvest bilateral mammaries without any concerns of sternal infection after devascularizing the sternum. This is the course over the last decade where stenting has, or percutaneous coronary intervention has steadily risen, and cardiac surgery has gone from 500,000 cases a year down to 200 or less than that. And I don't think there's any debate that that's going to continue, because patients like less invasive. We have to come up with a strategy. I don't think the strategy is trying to court cardiologists in our cases and do standard sternotomy cases anymore. That might have worked in the last decade, but trying to go by cardiology groups like some of our competitors, that just doesn't. We need to have a better strategy than that. We need to come up with a way that patients would want to come here themselves, not necessarily tricking cardiology people to refer to us based on contracts or those types of things. So this is the last 4 months that we've implemented our program. Our first case was on February 7th. We've done 44 cases. 90% of those have been from outside facilities. 5 of those cases have been from cardiologists practicing here. And those are cases that probably wouldn't have come here otherwise. We've done those by hybrid technique in 12 occasions, split fairly evenly between CABG first or PCI first. Some of them have been high-risk cases. I think redos are really good for this because you can come in through the left chest when they have a prior sternotomy and come in through virgin territory. One of which was even a heart transplant who had ostial LAD lesion, transplant vasculopathy, but had a good distal target and was able to leave the hospital after a 3-day length of stay. In general, though, these are low-risk cases. We have a few anecdotes of higher-risk cases, but we've recruited low-risk patients. 55 years old is my average age of these 44 cases. And when we enter their data into the STS risk calculator, which is actually an online calculator where you can enter in their various risk factors like a low ejection fraction and whether or not they have lung disease, they're less than 1% risk of mortality. This is my first patient, and here he is a week after surgery, clowning around outside the pool. This is a great case to have first patient, but we've had a lot of other ones like this. You almost have already won the game. You don't even have to know the rest of the talk. If I am able to get patients like this into the door, it doesn't matter if I do it robotically or open sternotomy, you're going to have good outcomes. You're going to have a better payer mix, and that's going to help your finances. These types of patients are actively employed, have Blue Cross Blue Shield insurance. They don't have, Medicare or Medicaid. And they're the types of guys that become real advocates for you. And word-of-mouth advertising is the most potent force of advertising there is. Television ads or billboard ads, nothing will equal that when you have a real advocate, a guy that wants to get back to work quickly and isn't told about this from anybody else. So as one of the people that I trained with, Norm Shumway, would always say it's not difficult to do surgery on these patients, it's difficult to get to do surgery on these types of patients. So you have to have a strategy to try to get them in. And that's where a business plan comes into place. You have to have something distinctive that patients want. And that's what I think cutting edge is all about. It's things that are directed towards their interest, patient-centered types of care. But you also have to deliver beyond that because they haven't heard about this at other places. They're a little skeptical, right? So they want to look at things that they understand, like customer service. Patients understand customer service, and if it's not good, they then start becoming skeptical about this innovation that's going on here. They also want to talk about all the options, so not just come and, I have a hammer and you're a nail, but this is part of a spectrum of things that we're offering here, okay? Robotic CABG is one thing. We could offer conventional, we could offer multi-vessel stenting, medical management. I'm an advocate of the robotic approach, but I certainly appreciate that patients might want a sternotomy so that they can have a proven track record, 30-year outcomes. Cutting-edge activities in general should be a variety of things if you want that shared decision-making to work. Less invasive cardiothoracic surgery in a broad sense, not just coronary revasc, but valve surgery. You could even implant ventricular assist devices less invasively, and I'll get more to that towards later in the talk. We have to implement this in a way that doesn't create controversy and minimizes the learning curve, and that's where the change management principles and putting together a team of people that are working together on those principles comes in very effective. This is a new concept. This is a cutting-edge activity in heart surgery. It's not been the way things have been done. The residency training program also needs to benefit from these cutting-edge activities. We have a 06 integrated program that Mike Moulton has put together and applied for, and I think we will be very strong to get it because no other center that's applied for it hasn't gotten it. And that is going to allow us now 6 years to train residents in cardiothoracic on these more intensive types of training activities. The less invasive surgeries take a lot longer for people to get to. We can't oftentimes get to that in 2 years. We need a comprehensive simulation lab which will allow us as attendings to do innovative things in the lab before we go into the OR. And in the same token, we can train our residents before they come into the OR. We don't want to expand our OR times. That's the best way to do it. And then I think clinical trials from some of the excellent research that we have going on in the division will also be something that will give us a unique, distinctive advantage that others don't have. But then to bolster that, we need to have customer service, building and motivating our team around that concept, organizing the office so that they understand customer services is important, and our cardiologists are our customers too. We need to be excellent in supporting their referrals and communication. Shared decision-making is really based on letting patients know what we're doing. We're not sharing decisions very well on patients that undergo a sternotomy at Northwest Hospital because they didn't know about this option. So in that sense, advertising now is not just a way of us making money, it's actually a community service because they're not hearing about it at other hospitals. If they were hearing about it, then it's a different argument. But if they're not hearing about it, we need to educate the community and the patients about this. We're not going to advertise like this. This is our competitor's Carondelet. If it wasn't completely ineffective, it would be very annoying. They say that the Arizona's leading team of cardiothoracic surgeons provide the most modern heart surgery available in southern Arizona. They don't even have a robot at this hospital. and they are providing the most modern surgery. It's okay, though, because it's completely ineffective. And this is the way 99% of advertising goes in healthcare. It's just these vague sense. It has no meaning to a patient. I guarantee you that no patient came to the hospital based on this ad. What we need to do is emphasize this plan. That's what an effective marketing approach would be. We offer something distinctive. When you come to us, you're going to hear about it because others aren't going to tell you about it because we offer it and they don't. Okay, that has meaning. That will draw patients in. I've seen it happen before. That's the marketing plan that we intend on executing. But that will bring controversy because that's one more innovative thing, is to try to draw patients into your hospital based on marketing. Okay? We have to continue to stick to these principles. Let's select a team of people that are behind the concept of robotics, behind the idea that we need to get the word out, that this has value. We need to define the metrics of success. Not everybody defines that the same. You've got to communicate that up front, a priori. What are the metrics of our success? What are the things that we're going to say that if we meet, we will consider ourselves having implemented this successfully? And I'll go through what we decided that was and how we measure up against those here later in a few slides. We need to do very good at measuring and communicating that progress. The hospital's been very helpful to me in giving us some infrastructure. We've hired 2 people that are designed to measure and communicate the progress of our results in cardiothoracic surgery, and that's all they do. And then ultimately, with that data, we feed back with a multidisciplinary group: anesthesia, cardiologists, nurses from the OR and the ICU and the floor, all sitting together and deciding how we're doing and changing things that aren't doing well. This is all stuff this is done before, actually, and specifically in minimally invasive cardiac surgery. There's a group up in Harvard that has specifically looked at the adoption of minimally invasive cardiac surgery in the early 90s. It was actually kind of a failure. It was rapidly adopted in a multi-center trial with robotics, and they only had 3 out of the 14 involved that actually succeeded, and they compared those 3 with the other ones, and they found the 3 that did well knew these principles, none of which had any formal management training, but they just kind of found it out basically by accident. And this is where this idea comes from, that this is really critical. So selecting the team. I don't know if you've heard of Ernest Shackleton, but he put out this ad: men wanted for hazardous journeys, small wages, bitter cold, long months of complete darkness, constant danger, safe return doubtful, honored and recognition in case of success. And he actually got about 100 applicants for this job. But he ended up getting his ship stuck in the South Pole, and I don't know if you've heard the story, it's very inspiring, but he attributes his success, his managerial success, and they have whole courses based on how he behaved and how he managed his crew to actually allow them all to survive. He attributes it to this step right here: selecting the team. People that responded to this ad and still wanted to join, those are the kind of guys that you want to get stuck with in South Pole and stick together as a unit and save them. And he did, and he brought everybody back. And I've been lucky that in the OR, ICU, post-operative care, with outreach efforts and cardiology, I've had those team members that have pulled together, and there's certainly a broader list than this, but I'm just pulling out specific names for unique recognition of people that I really appreciate their support, and I think we can continue this momentum based on this coalition that we've been gathering. We all have to address critiques in this, and some of your critics are your most helpful people. What I've heard here at Tucson and I've heard elsewhere is that robotics doesn't provide enough candidates. There are not enough people that need 1 and 2 vessel bypass. Why would this be of any value? Well, we're on course to do 100 cases per year, the cases that wouldn't have otherwise come here, so I think that answers that well enough, and I've found that in Baltimore, I found that in Boston, and so I think we have found that you tend to get people that you otherwise wouldn't have, people that cardiologists might have stented, but since you have this option, they're willing to give it to you. And then with the hybrid approach, we could take on more multi-vessel disease. Well, certainly there are candidates, there are people that aren't candidates, that need 5 grafts and have really small targets. But in general, I think there are enough candidates to have this program be viable. Another concern is that it's unsafe. You get caught with your pants down in any innovation thing where you don't have good exposure, you don't have good, in the case of heart surgery, stabilization of your coronary target, and it makes it look like it's unsafe. There are things you can do, though, to get around that. We'll talk about that in a second. People are concerned about the longevity of results when you do it through a small hole on a beating heart. This is a critique I hear very commonly. And then finally, it's too expensive. The profit margin for coronary bypass is shrinking. It's better for valves. It's better for heart transplant and ventricular assist device. Why do we want to spend a lot of money and time talking about an area where the profit margins are shrinking? So I'm going to try to answer these, at least these last three here. The reason why the safety is an inherent concern with less invasive techniques in heart surgery, and probably any approach, is that there's this red zone is where you're in trouble when you go into the OR. In a regular traditional coronary bypass, you go in the OR, you do a sternotomy on a patient that has coronary disease, okay? So that can stress them out. And then you have to manipulate the heart to cannulate. But once you go on pump, you start cardiopulmonary bypass, you're safe, okay? You're in the blue zone here. So that's a pretty short time, and in general, occasionally we see a guy really crashing after the sternotomy, but in general, because you can quickly get on bypass, it's not a problem. Well, with robotic CABG, it's different. So they come in, you intubate them, and then you have a variety of maneuvers that can take, anywhere from 1 hour to 2.5 hours before you're getting into the safe zone, inserting the chest ports, ventilating one lung, insufflating, manipulating the heart, occluding the coronaries to do your anastomoses. All these happen before you're actually revascularizing. Most of the times we don't go on bypass, so it's only when you're putting your graft onto the heart and reperfusing the heart that you're safe. So inherently there's a safety issue there. You've got to pick your cases wisely. You don't want to pick a guy who's unstable, has active angina coming into the room. That's not a guy that's going to do well with this longer period. But if they're stable patients, you can do just fine there. The real problems that influence this, that influence the safety, but more importantly, the morale about safety, is that there are unforeseen risks of morbidity, pain, and bleeding that can happen. The nurses aren't used to managing patients with intense pain after heart surgery because sternotomies don't really usually have intense pain. There can be bleeding happening because you don't see the port sites, for instance, as well. And in an open sternotomy, you see everything, usually pretty well. So those can be managed, but you need to educate people, and you need to have some kind of bailout options for when things are a problem. Long operative times, there's a lot made of that. I haven't really found that the clinical outcomes are bad for patients that even go up to 6 hours. But the key is understanding the backup plans. And so the way we do that is we have simulation training. I'm working with Aztec. They've developed this model for me. We're going to have one a little more custom made, but basically it's a model where we can put our ports in and practice an emergency thoracotomy in the ICU or in the OR. When you have your ports in and the guy codes, you've got to get those ports out, you've got to get your thoracotomy done. All this has to happen with the surgeon at the console now quickly going to the table. We have a pretty small room in room 4, so we've got to move the robot out of the way and get the perfusionists in position, and there's a lot of things that require a dress rehearsal to do, and we have done that. And these are the big things that we worry about in the OR. If you're sitting at a surgeon at a console and you've got the robot kind of blocking everybody else out and the heart gets ischemic, that's a problem. If you have RV puncture with an instrument and there's massive bleeding because of that, that's where you need to have that done within 5-10 minutes. You've got to have a definitive treatment plan in place. Sometimes the IMA branches, when they get lost, that can cause a significant issue. And ventricular fibrillation are the things that we rehearse, and in general, if you're effective at doing those things, you'll have no problems, because this is really the complete list of problems. We need to get our times down in the OR, so people that want to use the robot need to rehearse this before we ever step foot in the OR. It's amazing, actually, that the strategy up until now has been to go to a 8-hour training course somewhere, at a fancy hotel, and then come back and have 3 cases proctored, and that's it, you're trained. So we need to do better than that, and that's what I think this pack here that goes on the console, called a console trainer. You don't have to actually have a robot. You can actually practice this. I think Aztec has done this for a while now, computer simulation of your laparoscopic skills, and now we have this available for the robot. So the robot should be a strength for simulation training, because it's actually exactly simulating what you're going to see in the OR. Here's practicing a coronary anastomoses. But you can rehearse taking down a mammer. You can rehearse doing an anastomosis, open up the pericardium. All this can be rehearsed on the consult trainer before you ever show up in the OR. So if we want residents to operate, if we want new people to be doing cases, then this is the way to do it. I mean, I came here having had almost 300 cases of experience before I showed up, but I think for new people, this is going to be great. And then the other thing is when we get a hybrid OR and we're going to want to do caths on our own grafts, we should practice that before we step foot in the OR as well. So this is a dummy here with a fluoro screen, and you can practice catheter skills. And they can rehearse percutaneous valves, for instance, the technique of placing an aortic valve with a catheter-based technique. But the other thing you want to do besides rehearsing and training is measure outcomes and let the team know how you're doing. Feedback, okay? That's a very important principle of alleviating concerns about safety. And in cardiac surgery, we are fortunate that the list of things that define safety and define quality are well defined, that it's now publicly reported. We don't have to debate about what it is we should be measuring. This is it. There are things like surgical complications, renal failure, need for surgical re-exploration, obviously mortality, intubation, deep sternal wound infection, stroke. These are the clinical outcomes that are considered important to measure in terms of defining quality. And two of these are really right in the wheelhouse of robotics, because we're not doing any sternal incision at all, so deep sternal wound infection should be reduced. And in majority of patients, we don't go on bypass, and in none of the patients do we clamp the aorta, so that eliminates a lot of the source of stroke. You also have to teach your team how to monitor adverse events, because you can't just say what are our outcomes. You got to say risk-adjusted outcomes, right? I mean, everybody knows that the clinical risk affects your outcomes. So a lot of the people on our team weren't familiar with measuring an OE ratio, the observed rate of problems divided by the expected rate of problems, which is determined by their risk factors. Okay, so if you have an OE ratio less than 1, that's good. If you get up over 1.5, that's bad. Okay, that's a fairly simple way, and these things tend to swing a little bit more with a complication, so a better way to do it is the way they would do it at, for instance, Toyota, when they're measuring an error rate of any machine or their assembly line process. They would measure a cumulative sum, a control plot. And with this, you look at the cumulative sum of morbidity and mortality of observed minus expected, and you plot that out over the number of cases you have. So this is 1 to 160 cases. If you're accumulating rates of morbidity and mortality higher than expected, the curve goes like this, goes up. And then if gradually it gets less than expected, then the curve goes down. So what we saw in Boston was very different than what we've seen here. In Boston, out of the first 40 cases, 8 of them had complications. And so we saw a curve that went up to almost 5% higher than expected in terms of the rate of this combined rate of morbidity, mortality of those things that were on that New England Journal table. But then gradually it came down. We implemented at this point a multidisciplinary team approach. Whereas with the team approach started from the outset, we've had 3 out of the 40 cases, and the 3 were reoperations, so none were anything serious like a stroke or renal failure. We are now, after our 40th case, less than expected. So it's been a tale of two cities in terms of learning from the need to implement a team approach. Regarding the longevity of this strategy, I think that's a very important critique, and the data is still out. We have to actually do the studies. We are funded to look at long-term patency with CT angiography, and we've done that now from data as far out as 5 years ago when I was at the University of Maryland. But we don't have a 20, 30-year track record like traditional CABG. But I think a key point to remember is what I started out with the talk saying, is that we're harvesting bilateral mammaries. If you look at the literature on that, it's clear that it's better than veins, and every surgeon would agree to that point, but yet very few surgeons actually use bilateral mammaries. The national average is 6%, recent publication in Circulation. In Boston, they had a state database that monitored that and found 4%. And yet at UMC for the last 4 months, we've been at 33%. And that's because of the ability to use bilateral mammaries in the robotic cases without any consequence. I think that's what drives up that usage. Otherwise, probably very similar to the national average. This is the data from Cleveland Clinic, paper titled 2 IMAs are better than 1. It's been duplicated by many other groups. in patients that are less than 60 years old. Now, if you're older, then it doesn't quite have the same impact because they die before they show the difference between a single mammary and veins versus bilateral mammaries. But if you're younger than 60, there's a 30% difference in the rate of reoperation lifelong and a 5% difference in survival, both favoring bilateral IMAs. So the cost of robotic CABG, is it too expensive? And the answer to that is it depends on your learning curve. This is what I saw in Boston, the cumulative difference in the cost of robotic versus sternotomy cases. It was upwards of $10,000 more expensive, robotic cases versus sternotomy cases. And given profit margins that range between $3,000 and $5,000 for CABG, that's obviously not going to work. But it was focused during the first 40 cases. The same cases that had more complications are also spending longer time in the OR. We're not getting out of the hospital quite as quick as we would once we get into this zone where we are getting patients out. We're having more efficient operations. But it's all about the learning curve. How good you do on the learning curve will determine how you are doing in terms of your costs. So without the clear evidence of a learning curve here, we've actually had very favorable costs. The major drivers of cost, OR time, it's $100 a minute in the OR. Length of stay is another driver, and blood transfusions. And so we've been very good on those with no, certainly not worse than traditional CABG. This is data based on 2010 from UHC database. And this was manually collected, so they're from different data sources, but in general, we haven't certainly seen increased OR times, and that's because a lot of these cases are single IMA grafts. And with a single IMA graft, that's a pretty quick case. So looking at the Medicare patients, which is, I think, where you really want to look, because that's the least reimbursement. We get about 30% of charges for that, so we charge typically $100,000 for a coronary bypass. What we've seen here in our 20 Medicare patients out of the 44 was that average getting about $30,000 total reimbursement, about a little more than $25,000 of cost. So there's a profit margin there, which is good for a Medicare patient to be getting profit. But that doesn't cover any additional cost of this program. So, for instance, the cost to recruit a new chief, the cost to have a advertising campaign, that clearly won't do it. So we need to be able to increase revenue some way or lower other costs better. And I favor the revenue side of the equation because I think that's the strength of robotics. You've got to remember the peripheral effects. So patient satisfaction is a key purpose to doing this program to begin with. That's why we're doing it. And in general, University Medical Center does pretty good. The two most important questions out of the 10 HCAHPS survey questions that end up being very important in terms of hospital reimbursement and public reporting is how do the patients rate the hospital, and would patients recommend the hospital to friends and family? Okay, so we're better than average for the nationwide and Arizona hospitals in general. But if you look at robotic CABG patients, or actually if you look at our whole CT surgery service in the last 4 months, that includes robotic CABG, but includes our other patients as well, we're driving that score up by over 10% on each. So that's our contribution to this, and that's important because the patient satisfaction score now is no longer just something interesting to the CEO of the hospital and the various administrators, but it should be very interesting to you as surgeons because it affects something called value-based purchasing. This is a new plan where 2% of the total DRG payments for a hospital, so all the Medicare payments, in 2010 it would have equaled almost $800,000. Now that's all on the table. And you have to earn that back, and you earn that back by patient satisfaction and clinical score. The clinical score is based on mostly on skip measures and a few other clinical outcome measures. But that patient satisfaction now is critical because it affects that. And given our score, even though it was pretty good in satisfaction, we still would have lost $500,000. So you need to be in the top 10% on those scores in order to get back all that money. And this is the strength of robotics because, or any innovation, anything that is patient-centered is going to automatically get you better patient satisfaction scores. So I look at robotics not as a costly program that has a learning curve and has those potential problems and the marketing costs and things that are going to make your revenue stream be negative. You're going to lose money on your Medicare patients and that's a temporary thing. Ultimately, your ability to affect the value-based purchasing and get back perhaps up to $1 million a year because you're improving patient satisfaction and you're improving your quality outcomes. Also, the payer mix can improve. When I do, my average patient is 55 years old, so the majority of my cases are not getting Medicare. They're getting Blue Cross Blue Shield, United Health. Those guys pay 50 to 70% of charges, so automatically you're getting more money. Okay, but you got to have a way to draw those patients in. You can avoid never events. A sternotomy infection is a never event. That costs $100,000, $200,000 per year on an average cardiac surgical service, and we can avoid that by avoiding sternal incisions. We have more efficient bed utilization, so that means when a patient is discharged early, if we're expected to stay 6 days and you leave after 3 days, that's 3 more days that the hospital has to use for another DRG. Well, this goes on and on, but you're looking at a revenue stream that could improve by $1 or $2 million by this program. So when we're talking about, you know, losses of a few $100,000 during the learning curve, I think it's well made up for down the road, but it's not always. So robotic CABG is not going to solve all our problems. Ultimately, the competition will figure it out, and we need to translate this into other innovations. The metrics of success that we defined as a group were the following 4 things. Number 1 is cost. The number 1 driver of cost is OR time, so we said that we wanted to allow ourselves a learning curve. Certainly, 7-hour case is not great for long term, but we wanted to be less than 8 hours, and if it wasn't, that we would, as a group, figure out why that was the case. We have not seen any cases greater than 8 hours. Safety, the cumulative sum threshold of 4%. 4% greater than expected. We didn't want to exceed that like we did in Boston, and we haven't after 40 cases. We want to look at patient satisfaction and make sure it exceeds the results for conventional, because that's the whole rationale, and we have seen that the robotic patients are in the 90 percentiles for their satisfactions on the HCAP measures. And then staff, I don't know the answer to this. I have heard rumors that the April results for our morale survey was bad. The hospital sent out a survey of the culture of safety survey, and in 4 Northwest, the rumors are that it's bad, but I have to look that up. Certainly, if we're having morale problems in the unit, that'll have to be an area of focus. But I think that the idea of minimally invasive surgery and cardiac surgery is obvious. It's a repeating story. Orthopedic surgery, laparoscopic, everybody in this room is familiar with the advantages of it. Prostate, hysterectomy, even starting back as far ago as lumpectomy and x-ray and radiation therapy. It's really how stakeholders define value. The patients, the hospital, the payers, the training. You know, you got to be exposed to cutting edge stuff in a modern training program. You can't teach them the blue plate special and expect that they're going to go out there and be good. The NIH is even into it because they really are wanting to have comparative effectiveness research, and unless we're able to do minimally invasive techniques, we can't compare them to the traditional. But like I said, we want to translate this into other areas, and I think once we have an infrastructure in place, we can do that. This is a new device made by Heartware that they call the MVAD, miniaturized ventricular assist devices. They're the size of a quarter, and they can flow 4 and 5 liters, 80% of your cardiac output. The same thing that we now have that, you know, takes up a considerable amount of your abdominal space, now can be done in a minimally invasive robotic assisted way, because here's for instance one that implants into the superior pulmonary vein, and then the cannula goes into the left ventricle through the mitral valve, and then we would sew the outflow conduit onto the ascending aorta. Very easy anastomosis to do robotically. This one plugs into the apex of the heart and can drain this way, and then another one that goes through the apex of the heart and then sucks out of the LV outflow tract and ejects into the aortic arch. All these can be implanted through mini thoracotomy and avoiding a lot of the tissue planes that we create during ventricular assist devices that cause bleeding. And that's always one of the big triggers of inflammation and hypercoagulability and these types of things that happen in these patients that trigger the downstream clinical adverse events. So I think minimally invasive would be great in terms of attracting patients, but also in terms of improving clinical outcomes. Need to be rehearsed in an OR set or in a simulation lab, but ultimately I think with a group of people behind this, with anesthesiologists, nurses that all believe in this idea of minimally invasive, we can get it done. Another thing that's coming this summer, probably as soon as August, is the FDA approval of transcatheter aortic valve implant. This is the data that was used to approve it. It was a randomized trial published in New England Journal, and then after reviewing this, the FDA has indicated that they will be approving that this summer, and we have the plans to be the first in town to get it. And I think it's based on an established collaboration with cardiology already with these hybrid procedures and the fact that we're doing innovative things effectively. Blow up a balloon in the ascending aorta here with the aortic valve, and similar to the way you would implant a coronary stent, now you're implanting an actual valve for those of you that haven't seen this. So no sternotomy, no robotic ports. This is a percutaneous valve implant. All these technologies really are effective because they obey a basic principle of consumerism, which is the customer's always right. In the past, I don't think heart surgeons have got it, right? The patient is measuring in their mind a ratio between efficacy and invasiveness. The cost that they pay is invasiveness, and what they get out of it is efficacy. Heart surgeons have designed an operation that's to maximize efficacy irregardless of invasiveness. The patient's comfort zone is over here. They only did heart surgery if they absolutely had to. But now with these new innovations, and I think that coronary stenting, with rapamycin-coated stents should be considered one of them, but we are really in a much more effective zone, even if you did have to sacrifice some efficacy, and that's not always the case if you're doing bilateral mammaries in a robotic. But even if you did, the patients are still going to want it because it's right in the center of their comfort zone. So I plan on, in the next year, really pushing us that direction. Obviously, less invasive techniques in coronary revasc with robotic and hybrid approaches, with valve in terms of robotic and percutaneous approaches, in thoracic surgery with Dr. Daniel, with his expertise in the thoracoscopic but growing interest in robotics, and then with these miniaturized VADs. I think we have a program of distinction in heart and lung transplant that we'd like to continue to pursue with all the infrastructure and expertise in place. Congenital heart surgery is done well here, and that's another distinct advantage that we have. And then taking advantage of our research lab. We have 2 investigators in our division that are R01 funded, and allowing that to start to affect clinical trials, not necessarily taking clinical trials from industry, but investigator-initiated projects. So those are the types of things that I would like to pursue that I think fit squarely in that business plan of how to draw patients in here that will help our bottom line, help our residency program, and I think allow us to contribute to cardiac surgery in a way that it hasn't been really contributed to in the past decade. Thank you for your attention.